control and prevention. I'm delighted to welcome you to today's webinar, Using Peer Assessment and Root Cause Analysis to Assess and Improve Health System Emergency Response. Today's webinar is sponsored by the Association of Schools and Programs of Public Health and features two subject matter experts from the Harvard School of Public Health Preparedness and Emergency Response Learning Center, or PERL. CDC is providing funding for 14 PERLs across the U.S. and provides training to state, local, and tribal public health authorities within self-defined service areas to meet partners' unique workforce development needs in the area of public health preparedness and response, specialized training, education, and consultation. During this webinar, our featured speakers, Dr. Michael Stoto and Ms. Rachel Piltch-Loeb, will discuss the challenges associated with addressing public health emergencies and how root cause can improve organizational learning and public health response to these emergencies. Here to provide an introduction to navigating today's webinar is Ms. Rachel Eisenstein, Program Manager at the Association of Schools and Programs in Public Health.
Thank you, Gail. ASPPH is pleased to present today's webinar. In a few minutes, the presentation will begin, and then following the presentation, we will have an opportunity for your questions to be answered. Please note that your audio is muted. However, if you have a question at any time during the webcast, you can type your question into the question box. The question box is opened by clicking the small white arrows that are in the upper right corner of your screen. After the presentation concludes, we will address as many questions as time allows. Today's webinar qualifies for 1 Certified in Public Health Continuing Education credit. To obtain your 1 CPH recertification credit, please complete the webinar evaluation. You may access the webinar evaluation through the ASPPH.org website. Click Events at the bottom of the home page, and you will see the webinar description as one of the featured spotlights. Click on the spotlight, and you will find a link to the webinar evaluation. You can also visit shoppublichealth.org and find the evaluation under the Certified in Public Health Continuing Education Credit section. The required passcode you will need for the evaluation will be provided at the conclusion of the presentation.
Thank you, Rachel. Our moderator for this webinar is Dr. Joan Chaffee. Dr. Chaffee is the Associate Director for CDC's Public Health Preparedness and Emergency Response Learning Office.
Thank you. Our first presenter is Dr. Michael Stoto. Dr. Stoto is a professor of health systems administration and population health at Georgetown University. As an epidemiologist, statistician, and health services researcher, Professor Stoto's research focuses on public health practice, especially with regards to preparedness. Dr. Stoto is the co-principal investigator of the CDC-funded Preparedness and Emergency Response Research Center based at the Harvard School of Public Health. Our second presenter is Ms. Rachel Piltch-Loeb. Rachel Piltch-Loeb is a research assistant at Georgetown University and a student at the Bloomberg School of Public Health at Johns Hopkins University. Ms. Piltch-Loeb has supported the Systems Improvement Project of the CDC-funded Preparedness and Emergency Response Research Center, which is based at the Harvard School of Public Health, and has worked on this for the past 2 years. I'd like to turn it over now to our presenters. Thank you.
Well, thank you, Joan, and thank you, everyone, for tuning in. This is Mike Stoto, and I'll be doing the first half of the presentation. And I want to begin with something that I think we all agree, that public health emergency preparedness systems must learn from critical incidents. These are the events that test how well the system performs, and we have to make sure that the lessons learned from these are both valid and implemented to improve future responses. And we've taken this approach in our work in our CDC-funded Preparedness Center, looking at things like the anthrax attack and SARS and Katrina, and most especially the H1N1 influenza in 2009. There actually are a variety of ways that you can take to assess public health emergency preparedness. Perhaps most common is the unstructured assessments, where someone asked a question, are you prepared? What have we learned? Without any formal approach to answering those questions. I think that many people are familiar with the inventories and capacity assessments that are regularly done, often as a condition of funding, that essentially have asked, have we done what's recommended, which can be very useful. One of the things we're focusing on in our center is using drills and exercises, not just as a training device, but asking how would we be prepared to see how different public health systems would respond to particular events. And the focus for today's presentation is how can we actually learn from actual events and critical incidents. Were we prepared? And most importantly, what gaps in preparedness exist? Oftentimes, these last two, drills and exercises and actual events, are evaluated and assessed using the HCEP exercise evaluation guides and after action reports. And we'll be saying a little bit about that as we go forward. So I want to begin by talking about some of the problems with typical HCEP after action reports. And I stress typical because there are certainly good examples that are good counterexamples to this. And in fact, when I made this presentation earlier, somebody I spoke to seemed a little offended, and I said, well, when I learned about what he was doing, I think that he was actually doing some of the things that we're talking about today. But let me begin by stressing typical. One is that they focus on target capability lists, which really are, in many cases, capacities rather than capabilities. I'll say more about the distinction between those two things in a moment. They basically often look at one TCL or observation at a time and assume that the plan applies to the situation. Like, for instance, in H1N1, they assumed that the vaccine would be available all at once and the demand for it would be high, neither of which were true, as everyone now knows, in the fall of 2009. They also sometimes assume that the NIMS model for communication is in play, but sometimes in the heat of event, other communication methods are used that may be not quite as effective. Typical after-action reports often focus more on form rather than probing objective analyses. The root cause analysis, which we'll be speaking about today, is optional and often not done, and even lessons learned are sometimes not pulled out in a formal way. The improvement plans are often missing altogether or not the basis of a very good analysis. And many of these after-action reports are prepared by emergency planners who are good, and that's their job to do it, but the subject matter experts who were involved in the response most directly have gone on to their regular job. So the primary challenge that we want to address here is that critical events are singular events. They're unique in their context and specific. Many of us were taught that rigorous evaluation focused on patterns discerned through statistical analysis of large samples. We hear things like, don't let your estimates be skewed by outliers, and the plural of anecdotes is not data. And you know, as a statistician myself, I understand that perfectly well. We also see that the quality improvement methods that we often see in healthcare and increasingly in public health rely on statistical measures. But the singular nature of these emergencies, they basically don't recur frequently in the same way, in the same place, makes it difficult to conduct statistical measurements. And so the question that we face is, what do you do when all you have is a small number of singular events? There are other challenges, too, having to do with the nature of public health and public health emergency preparedness. One, of course, is that the public health system is fragmented. We have city, county, and state health departments, and of course, federal agencies like CDC. And at the state and local level, the structure and the function of these agencies varies. We also know that there are many non-public health partners involved. Here we borrow a figure from an Institute of Medicine report about the public health preparedness system. And you can see that there's healthcare, policymakers, the healthcare delivery center, emergency medical services, the media, employers and businesses, and all sorts of others. The communities circle on the left there is really meant as a placeholder to represent lots of other different organizations. And we also know that what makes up an effective response is complex and multifactorial. It's not always clear in advance or even afterwards what would be most effective and needs to be done. and we simply don't know the counterfactuals. We don't know, after an event has taken place, what would have happened if we had taken some other course. Would it have been better or worse, in what respects, and so on. So let's discuss some possible solutions. One is the importance of focusing on capabilities rather than capacities. Capacities represent the resources, the infrastructure, the response mechanisms, knowledgeable and trained personnel that a public health system has to draw upon. The inventories, however, of the inventories of these capacities may not predict well the response capabilities or the outcomes that will result when we try to employ these capacities. Capabilities, on the other hand, represent the actions a public health system is capable of taking to effectively identify, characterize, and respond to emergencies. This can be assessed in small and large events, and this graphic that I found, I think, explains it well. The ladders that this man is standing on represent capacities. Clearly, ladders are important for climbing over the wall, but if you don't know how to use them, you won't be able to climb over the wall, which represents a capability. So for quality improvement purposes, it's important to ask how and why the system performed as it did, not just specific capabilities, and also, but not only, how many or how well the system performed. We need those qualitative questions, how and why, in addition to the quantitative kind of questions, to really understand in a way that we can be used to improve the system. That's the big point, and what we want to do today is really talk about how we can do that kind of analysis. So one tool that we've been using was actually developed at RAND a couple of years ago. I was part of the team, and Dr. Lurie, now the Assistant Secretary for Preparedness and Response, was the lead on this. And what we had developed was an established method for establishing a health system's emergency response capabilities and for conducting a candid systems levels analysis. It's based on a set of structured discussions with public health leaders and key staff and the stakeholders involved with the response. It involves a neutral facilitator and a no-fault approach, and during this facilitated look-back discussion, which takes maybe a half day or so depending on the complexity of the issue, you go through each of the major decision points and issues, and you discuss the dimensions and probe the nuances and understand what really went well and what didn't go so well. The reference is there if you want to find out more about this, and it's included in the material we'll reference at the end for the things we're talking about today. Now, root cause analysis is a technique that's used in a variety of different industries and increasingly in healthcare. And what we have been trying to do is develop this root cause analysis approach in public health emergency preparedness settings to analyze these singular critical incidents. The goal of root cause analysis is to move from the superficial proximate causes to a system-level root causes by repeatedly asking why each identified problem occurred. If you look at the textbooks, some say it's as easy as asking why 5 times. Every time someone says something, you ask why again. But in fact, I think it's more complex than that, and we'll give some examples to show how it can be done. It focuses on the primary response challenges, the immediate causes that led to those challenges, and the contributing factors. And these contributing factors can be things that are modifiable, and those are the ones we want to think about changing so we improve in the future. Unmodifiable or predetermined root causes, things that we at least have to be aware of and find ways to address them in the future. And what this does is identifies lessons learned from the adaptations and solutions that met the response challenges. So the root cause analysis model includes a number of components: response challenges, objective or goal, immediate causes, contributing factors, which are the root causes, the lessons learned of that adaptations and solutions. The benefits of this are that we can get a variety of stakeholders involved to address critical issues in a way that is positive rather than trying to attribute blame. And we also discover that when focusing on the root causes, we tend to identify system issues rather than personnel issues. It's not a problem that Bill did something wrong or that Mary did something wrong, but that the system made it too easy for the result to turn out in a certain way. And it's easier to talk about how we can change the system rather than try to correct what Bill and Mary did in the future. So let me give you an example. This was based on an exercise that we did last year, but where we went and investigated a salmonella outbreak that took place in Alamosa County in Colorado in 2008. Alamosa County is a rural community in southwestern Colorado that has a population of around 15,000, and it's one of the poorest in Colorado. It's about 4 hours south of Denver. Many of the citizens are, well, I'll show you the map. Alamosa is way down at the bottom here. Many of the citizens are homebound or have limited modes of communication. There's large minority populations, Hispanic and Mormon. And there's one public school department and one state university in the county. The county also includes the city of Alamosa. The county runs the health department, which in 2008 wasn't a full-service health department as it is now, but actually was named the Alamosa County Nursing Services, stressing the fact that it primarily provided nursing services and didn't have environmental functions and things like that. The county health department is supported by the regional epidemiologists, preparedness staff at the county level, and so on. The city of Alamosa has a separate administration, and among other things is responsible for public works, including the management of the water supply. People who work for the city were aware at this time in 2008 that the water system was not chlorinated and that there was at least one break in the water system. And both of these facts will turn out to be important as this story develops. So here's Colorado with Alamosa in the southern, central southern part, and there's one city of Alamosa right in the center of the county. So here is the timeline that describes the major events we'll be speaking about. On Friday, March 7th, it seems that these things always happen right before the weekend on Friday, the first cases of severe GI disease presented at a local medical facility. The next day, the regional epidemiologist assembled a team and started to interview cases. They took samples from some of the cases, sent them to the state lab, and by Wednesday, March 12th, the state lab confirmed that the cause was salmonella, and that at that point 25 people were ill. Originally, many of the people who were ill had gone to the McDonald's in town, and many people and the officials originally thought that McDonald's may be the source, but it turns out that one infant became ill and who had only consumed infant formula and not any McDonald's food. And that, together with the mapping that was done, suggesting that people were from all over town, suggested that maybe the water system was at fault. And on March 19th, the water system actually was confirmed as a source. And what this picture here shows is literally a break in the water system that explained the contamination. Now, the thing to point out here is that it was almost 2 weeks between when the first cases were discovered and the water system was confirmed as the source. A typical after-action report may have said, well, it took too long to find the source. We're able to identify the vector, the salmonella, early, but the source itself took almost 2 weeks and stopped there. But that wouldn't be very helpful in terms of what do you do to improve the system to improve responses in the future. So the way that we think this can be addressed is like this. This is one part of the analysis that we were able to do when we were working with the folks in Alamosa, focusing on this essentially identifying the source. So the key aspects of the story arc, were that residents of Alamosa County were becoming ill with a severe GI illness at abnormally high rates. It was quite obvious. About 20 cases were identified before the Public Works Department admitted that the water system could be to blame. So the objective of the response here was to identify the source of the outbreak causing residents of Alamosa to get sick and to mitigate the spread of the disease. You can't stop the spread until you know where the source is. And this is an example of one of the CDC preparedness capabilities, number 13, surveillance and epidemiological investigation. So laying it out in root cause analysis terms, the response challenge here was to identify the source of the salmonella outbreak. Not the agent, salmonella, but how did the salmonella lead to exposure to people. And we found, after talking it through with the participants at this meeting, that there were two immediate causes. One is that salmonella is not commonly found in the water supply. It's common in food and so on, but not water, so water wasn't an obvious thing to check. And secondly, the city of Alamosa runs the water system, but the county health department was responding to the outbreak. So although there was knowledge that there was a break in the water supply and the water wasn't chlorinated, the public health system didn't have that knowledge. The public health department, I'm getting into the contributing factors here now. The public health department, which was called the nursing services department at the time, remember, didn't have an environmental health component. And the city and the county, despite their co-location, even same name, didn't have a history of working together well. So what this suggests here is that there are a number of lessons for systems improvement here. First, the city and county must communicate to conduct outbreak investigations successfully. The water supply must be chlorinated to prevent further outbreaks in the future. And public health needs to develop an ongoing relationship. Public Works needs to develop an ongoing relationship with public health and emergency operations at the county level. These are the root causes, the contributing factors, and some of the things that we think can be done to address it. Again, we're trying to get around what may be typical in after-action reports. It took too long to find the source, and get at some of the root causes that can be addressed to improve the response in the future. I'll say one more thing about this before handing the presentation off to Rachel Piltch-Loeb. And the idea here is some people sometimes are confused about the directionality from left to right or from right to left. And the way we think about it is we begin by the objectives and response challenges and work backwards to identify the contributing factors and root causes, and that teaches us about lessons for improvement. Although in a world where we think about causality, it works in the opposite direction, that these contributing factors lead to the immediate causes and then, of course, the response challenges that we observe. It really involves some iteration going back and forth to identify these root causes effectively. Okay. At this point, I want to turn back to Rachel Piltch-Loeb, and who'll speak about the peer assessment process more generally.
Hi, everyone. To pick up sort of exactly where Mike left off, the process that Mike just described was conducted expanding on both the facilitated look back and the root cause analysis process to bring together members of this interdisciplinary system that responds to these sort of critical incidents that we've been talking about. And a way in which we have attempted to do that to sort of avoid some of the challenges that we've seen with typical after-action reports, where it's often difficult for individual jurisdictions to ensure objective or systematic and reliable analyses of their own response due to that limited time or resources that are able to be given to an after-action report is to bring together peers from similar jurisdictions to help a given jurisdiction that has experienced an incident to analyze what's happened in that particular case. So in Alamosa, Colorado, for example, we brought in a practitioner who is on our project advisory panel from Johnson County, Kansas. And what she was able to do is work with us and the members of the community and various organizations, the public health department, this nursing services department, which is what it was called at the time, as Mike mentioned, and help facilitate the discussion going on at the table using her own sort of knowledge of the public health systems and practices, and in addition to sort of helping to draw out some of the systems issues that others were talking about at the table. So we've sort of called this the peer assessment process, and it really just incorporates this extra element of having an individual familiar with the public health system from a different jurisdiction in contributing to that group discussion. And that practitioner was given just-in-time training when we sort of arrived on scene in Alamosa, and was able to valuably contribute to the discussion for both their own knowledge, but really for the knowledge and lessons learned that were drawn out in that root cause analysis diagram that you were just seeing. So some of the lessons learned from this peer assessment process, which not only was field tested in Alamosa, Colorado, using the facilitated look back and root cause analysis methods, but some specific lessons learned were that participants contribute a variety of perspectives to the incident, and that includes this peer practitioner that we were talking about. That the process encouraged thoughtful engagement for those with different viewpoints. Sometimes these incidents that occurred can be challenging, and they can challenge people's communication with each other and communication or abilities during the incident, and bringing people back to the table for a respectful engagement process was valuable. So, because oftentimes we found that people had not even engaged since responding to the incident because they had been frustrated, or because they don't engage besides when they are responding to a critical incident. So their perspectives were never shared. We also found specifically that this peer assessor can contribute and facilitate a meaningful discussion, and really that the discussion can be an effective way for different jurisdictions to share practices with each other. There was sort of a lot of communication that was increased cross-jurisdictionally. And finally, that the follow-up reports that come from these specific peer assessment, root cause analysis, facilitated look-backs can be used to improve the existing after-action reports or existing reviews that have occurred locally. You'll see that, the incident we're talking about here, the 2008, was in 2008, excuse me, which was clearly years before we'd gotten there, but the level of detail and really respectful engagement had not occurred until this process, and that sort of was reflected in many of the comments we received from the participants. Similarly, in the example from the West Nile virus outbreak in 2012 in Dallas, they really used some of the things that came out of the meeting to improve their existing after-action report that was in the works. So if you'll excuse me for one moment, let's see if the slides can advance. There we go. So this goes back to really what Mike was stating at the beginning of the presentation, that it is important to learn from critical incidents. The National Health Security Strategy called for systematic quality improvement to improve our national health security. That's from a report in 2009. And there's really not time or resources to not take advantage of the lessons that unfortunately have to be learned when responding to a given incident. And so often, though, after a report is written, say, it can get thrown on the shelf because people go back to their day jobs, and those lessons learned are not, don't turn into practices learned or practices changed. And so the beginning of our research on systems improvement in public health emergency preparedness, or I guess not the beginning, but one phase of our research sort of looked at what would it take for some of those lessons learned and given incidents to really be documented and shared across jurisdictions. And we came up with this notion that a critical incident registry for public health emergency preparedness would be one incredibly valuable and unique way in which to do that. And the concept really is that there would be a database of incident reports filed by given health agencies that have responded to a critical incident. And that can be something that has really tested the ability of the jurisdiction to respond. Critical incident registries are actually very common in other industries. The aviation industry has been using them since the 1980s to sort of document when there would be near misses or adverse events that occurred, and the use of the registry has really led to consistent changes and improvements specifically in actual plane mechanics and in operational procedures. So some of the objectives you see here are, one, to drive organizational improvement through careful post-event analysis of an organization's own events to facilitate the identification and sharing of best practices, similar to those practices we were talking about that were shared in the peer assessment process, and to also facilitate cross-case analysis so that you're able to sort of examine how different mechanisms or different operational practices are used in different settings, and to see what is really being successful in different places. So that one given jurisdiction that may not have the expertise in responding to, say, a disease in the water supply, like what happened in Alamosa, could look into the critical incident registry and see that that small jurisdiction dealt with it in this way, and really draw on that example for their own purposes the next time. So it would really be a valuable database to share what's happened and the way in which the response then occurred. So I was mentioning that what would be included in a critical incident would have to do with really the capacity of the jurisdictions that had responded to it and what they deemed as critical to their ability. So different individuals or different groups would define the scope of a critical incident differently. We envision a critical incident to be one where public health played a significant role, meaning that one of the that capabilities was tested, or many of those capabilities were tested, and really that the incident was meaningful, and that can be meaningful in many ways. The magnitude of social disruption, or morbidity or mortality, the sort of revelation that came from responding to the incident in revealing something that had not previously been known to the jurisdiction or to the responding agencies, something that significantly altered the system's behavior or beliefs, something that helped the jurisdiction or responders to identify best practices, something that captured the CEP community's attention, meaning it was talked about in the news media or among professionals. And finally, that there was an appropriate scope, time, and organization to capture the event. And what we mean by that, and it's really critically important, is that the incident can be focused on in something called, what we like to call, a bite-sized chunk. And that is, say, you can draw out pieces that happened and that can be focused on, so one capability or one element of the response. So if you think about the 2009 H1N1 outbreak, which is what we used to create some sort of sample entries that could be used to populate a critical incident registry or a CIR, sort of focusing on perhaps vaccine distribution or communicating with the public as bite-sized chunks of that really prolonged response. Because one of the things that's unique often about public health emergency responses is the duration within which that happens. And a lot of things can be tested and challenged within that time period, and it's valuable to attempt to capture a variety of different time points or chunks of the incident. So the hope would be that any or all of those could be captured in various capacities in this critical incident registry. So what are some critical incidents that we envision in the last decade? Some of them Mike mentioned in the beginning that some people on our team have worked on are anthrax or smallpox vaccination, emerging pathogens, the various influenza outbreaks, especially H1N1, foodborne outbreaks, natural disasters, the Boston Marathon bombing, and other sorts of incidents. Now, to sort of frame what we're talking about and what I've been mentioning in terms of a CIR in the context of some of the other projects that we've, or methods, excuse me, we've mentioned throughout this presentation, if you sort of look at this slide, and I know that there's a lot of colors and arrows, but bear with me. Right now, in the top left corner, you'll see sort of the self-prepared after-action report and improvement plan. And in the blue box, you see that there are tools that are often used to support the preparation of that plan. And those tools are some existing tools include surveys or focus groups, and we really see that our root cause analysis tool could fit in well to the self-preparation of an after-action report or an improvement plan. And it could really stand on its own to support those who are sort of still comfortable preparing their own AAR. Another way, though, that root cause analysis tool we introduced you to in the beginning could support other elements, such as an external assessment, like those that we were talking about with the facilitated look back and peer assessment, is through that second blue arrow pathway over to the second yellow box of external assessors. And finally, both the external assessors and the self-prepared after-action reports could populate a critical incident registry. So using the method of the root cause analysis, which can support both a self-prepared AAR or an external assessment through peer assessment, those reports could populate a critical incident registry and really build a valuable database of incidents that could serve a multitude of purposes, such as sharing best practices, ongoing public health emergency preparedness research, and individual systems improvement. Now, an individual critical incident report could come in a variety of ways, but one way that we have envisioned a report structure is to really encourage this cross-case analysis. So it's a structured summary that would be searchable for given practitioners and researchers. Relevant context is captured, similar to that story arc that you saw on the root cause analysis diagram, but with some additional detail provided. There's a timeline, such as the one you saw for the Alamosa example, and really then an analysis of the public health emergency preparedness system's role. And that doesn't have to only be the public health department, but can include sort of that broad system that we've been discussing. We really would hope to have just enough detail to really understand why given organizational functions or mechanisms, as we call them, worked in that specific context, to understand what happened. And finally, of course, it could also be searchable by the public health emergency preparedness capabilities or other particular topical incidents if that was of interest. Now, reporting itself, there are a couple different ways that existing critical incident registries get reports. There's mandatory reporting requirements that if an incident is not reported, there are legal penalties. One of those is managed by the FAA. Another potential way could be as a condition of funding, such as through cooperative agreements, or of course there could be voluntary reporting. And some best practice sharing databases, such as one managed by NACCHO, does encourage voluntary reporting. So this would ideally take that one step further. We, of course, recognize that there are barriers and incentives to reporting. And one of those, some of the barriers that we've just briefly wanted to mention and sort of recognize are one, the staff time, effort, and ability to objectively analyze what's happening, or for an outsider to come in and really assist in that analysis. We recognize that there are embarrassment or liability concerns, but we've sort of tried to think through that in in some of the incentives and benefits of this critical incident registry and these other methods that we've talked about. The incentives to reporting are really this goal of organizational learning and improving the system overall for individual jurisdictions and nationally. Other incentives are providing support, such as with the root cause analysis tool and training that I'll get to in one moment, through peers, through schools of public health, which have the expertise to support this analysis, and to then also try and reward thoughtful reports through whether it's awards or publications or something that would be meaningful to practitioners. Now, finally, in terms of next steps, we are continuing to develop the training materials and approaches. We have an online toolkit and training on some of these methods. There are 2 existing video modules and a 3rd that's in the process specifically on just the root cause analysis tool. We also have some case examples on the 2 incidents that we've talked about, the Alamosa, Colorado example and the West Nile virus example. We are working on dissemination of the root cause analysis tool. And we're also continuing to try and refine these methods, both root cause analysis and peer assessment. We have one specific case in progress in Kanawha, Charleston County, West Virginia, in analyzing what happened in the response to the chemical spill in the water supply there back in January. So we're continuing to have discussions with NACCHO and ASHO and then other organizations and practitioners that are interested in these projects, other organizations that may be interested in hosting a registry and supporting this process. And we are certainly welcome and would welcome your suggestions on how to do that further. Now, finally, that's the extent of our presentation today. For more information, you can go to the website hspph.harvard.edu/h-PERLC, P-E-R-L-C /. You can contact myself or Mike Stoto for any additional information on these projects. And now I think we'll open it up to questions.
Thank you. Thanks to both of you, Dr. Stoto and Ms. Piltch-Loeb. We now have a few minutes to take questions from our audience. As a reminder, please type your question into the question box in the right corner of the screen, and you can open that box by pressing the arrows. And we have some questions coming in, and I'll start off with this one. How are the methods you describe different from standard after-action reports and other existing tools?
Well, let me take a stab at doing that one. I think in some cases, the people who do this well are already doing some of these things. But what we're trying to do in these methods is to get beyond some of the surface findings that people often put in their after-action reports, and to really understand what were the root causes that led to those outcomes. We want to avoid fighting the last war and saying, what went wrong here, and rather focus on what can we do so that when something similar to this, maybe not exactly the same, comes up in the future, we can do a better job. And that takes a little bit more thoughtful probing analysis than is often the case.
Great, thank you. Dr. Stoto, I think you mentioned at the beginning of your presentation something called NIMS model of communication. Can you please explain what that is?
Well, there are standard communication approaches like the incident command system and joint information centers and so on that FEMA and the Department of Homeland Security are trying to get all emergency responders to use. One of the things that we found in the work that we're doing in the water problem in Charleston, West Virginia, is that they weren't used during that, which led to some confusion during the early parts of the response, and different parts of the system, the health department, the emergency responders at the state and the local level and so on, weren't all in on the decisions being made, and that caused confusion and difficulties going forward.
Thank you. The next question is, are people really willing to speak openly about the failures of the systems they work with?
you know, it's really surprising to us in some ways that they are. Many of the people that we pulled together, Rachel, you may want to say something about this in Colorado, in a moment, are really interested in these issues and want to have the opportunity to do it, and welcome the opportunity.
Yeah, I think just to expand on that briefly, I absolutely agree. In Colorado, for example, there was appreciation from the people who were there. One, that the incident was being recognized sort of on a broader scale, and that it would become sort of part of these materials, and we'll write on the topic. And there was, because of the time that had gone by, there was interest and acceptance in trying to talk through some of the issues, because the folks there really were interested in trying to make some changes by that time.
Thank you. The next question is, why would peers want to participate when they are already limited in their time at their day jobs?
Well, I think that, you know, public health practitioners want to do a good job, and I think that they see this as an opportunity to learn about the system. So there's really two parts. You know, one is, why do the people who are involved participate? They want to learn about their own system. But you also say, why might people come in to be the peer assessors, the peer evaluators in all this? Why should they go to someplace else? And we find that that really is the way to learn. When you go to meetings, you often see people telling stories about what happened, and hearing about something and saying, here's what we did, and so on. And you know, when events happen so infrequently, thankfully, as they do in public health emergency preparedness, everyone has to learn from one of these things, not just the people who responded directly. And so this is a way to basically to formalize that kind of natural tendency that people have to want to learn and to share their expertise, and to collectively develop the systems, in the broad sense, ability to respond in the future.
Thank you. And the next question, how do you plan to disseminate these tools?
Do you want to take that, Rachel?
Yeah, some of the things that we already mentioned, especially the online modules and the toolkits, are ways in which we're sort of hoping to encourage other practitioners to use these methods, continuing to participate in training sessions at the NATO Public Health Preparedness Conference. We're sort of writing specifically on how to guide on doing the root cause analysis tool with some of the practitioners we've worked with, and we're sort of still looking for case study examples to work with practitioners to continue to refine these tools as well. So if there's interest in that, we would be happy to talk to folks as well.
Thank you. The next question is root cause analysis appropriate to measure the effectiveness of responses for large-scale or catastrophic events?
Well, I would say that it's not only appropriate, but it's necessary. But maybe the problem is the word measure. And I think that when a government funding agency is holding the people that it funds accountable for their work, you think about doing measurement in a quantitative sense. And root cause analysis may not be the best thing to do for that purpose. There, you really want to answer questions like, how many of these resources do you have? How quickly can you do so-and-so? And quantitative questions like that. When the goal is to improve, that only can be done by understanding what happened and what can be and its implications for the future. I mean, the events that we see are never going to happen again in the same place in the same way. But but they can help us to understand some of these core capacities, like the ability to do surveillance and identify the source of the outbreak, or to communicate with the public about certain issues. And it's been our what we have found in our work is that this root cause analysis is really critical for learning things that are more generalizable than just the specific response to a specific event.
Great, thank you. How does this proposed database relate to the CIDRAP Public Health Practices site in LLIS?
Well, let me say about LLIS. This is the lessons learned, what is it, something shared, that's developed by the Department of Homeland Security. That is something that covers all aspects of emergency preparedness, not just public health. So one way that it would differ is that these events would focus on the public health response. Even in some of the general results that are in that database, there's not much of a public health focus, even when there was a public health response, because they're being prepared by the county emergency coordinators rather than the health department emergency coordinators. The other thing, I think maybe the more important thing, is that we would make sure that they are structured, that the incidents in our CIR are structured in a common fashion, so you can find certain things, and that the analysis really is deep and probing. Some of our colleagues at Harvard, led by Elena Savoya, actually did an analysis of the reports that were filed in LLIS for H1N1 and for a couple of the hurricanes, and that paper has been published now. And they found that some things that you think would be really important sometimes weren't even covered, and often the analyses were not very probing. And the kind of things that we're talking about were not being done. You know, when I talked about typical after-action reports towards the beginning, that was based in part on looking at the reports that we see are filed in LIS and similar symptoms. I'm not sure about the CIDRAP one, but maybe it's like the NACHO database that Rachel mentioned, and there are oftentimes good analyses in those, but there's no requirement that they be done in a structured way, so it's easy for people to learn from them. And there's often, and sometimes they don't have the kind of probing analyses that we think are necessary.
Great, thank you. All right, we have time for just a couple more questions. This one is, how do you envision the root cause analysis takes place in the event of an incident, and who would be part of that team?
Well, we really have a couple ways that it can happen. One, it could be done purely by the people who were responsible for responding, or we think that there's sometimes value in having some objectivity from some outsiders participate in that, and the peer review process is one way for doing that. You could also have people like us from academia work with some of the local responders as well. But in terms of doing the analysis, one of the things that we find is important is having all the different perspectives that were involved in the response involved in the analysis. And that the lack of that is, I think, a problem with some of the typical after-action reports that we see. They're often done from the point of view of one agency, and then maybe somebody pulls them together. But these facilitated look-back meetings that we discussed, and the other kind of activities that we've done in the peer review, the peer assessment work, involve bringing people together. And we often find that some people will say, well, I was thinking so-and-so. And other people saying, is that what you were thinking? I really didn't understand that at the time. And it's really the engagement of the people from the different sectors that I think helps to move from the right in terms of the challenges to the left of our diagram in terms of what were the root causes that have lessons for the future.
And I think one thing just to add to that is one of the the nice things about this root cause analysis is the actual visual diagram in that, you know, it doesn't have to be, it would be ideal, as Mike was just describing, to have those various voices heard and to have the most rich root cause analysis, but to orient those who are able to participate in whatever sort of analysis is happening around that diagram so that they're not, individuals are not focusing on each other, but rather on that process that is illustrated can just be valuable in itself.
Great, thank you. And then one last question that's a follow-up. Does root cause analysis require additional data collection, or is there an opportunity to use existing data methods and sources that are part of the AAR?
Yeah, it really is. It helps to build it on an existing AAR. In both the Colorado case that we spoke about and the other one where we tested it in the Texas West Nile virus, there were existing AARs that we found were helpful starting points. And the work that we're doing in Charleston, West Virginia, we don't have an after-action report yet. So we tried to fill in the gap by interviewing people to make sure we understood the issue. But fundamentally, this is not about gathering new information. It's about looking at the information that exists, bringing together people from different perspectives, and analyzing and really understanding the implications of what we saw, rather than doing new data collection.
Great, thank you. Well, that's all the time we have for questions at the moment. But Rachel, if you still have control of the slides, if you could go ahead and advance 2 slides so that people could see the website you were referencing. One more slide. Yes, perfect. I'll give people a minute to copy that one down. You can see the contact information for either Dr. Stoto or Ms. Piltch-Loeb right there, and the website that they were referencing. Thank you. And then,
and of course, I want to make sure we acknowledge the support that we got from CDC for doing this work.
Mm-hmm. Great, thank you. And then, Rachel, if you could just go up one more slide, and I'm going to actually turn it over to Gail now for concluding remarks.
Okay, thank you, Rachel. On behalf of ASPPH and CDC, I would like to thank everyone for joining us today. With special thank you to our presenters, Dr. Stoto and Ms. Piltch-Loeb. Within the next few days, this recording of this webinar will be posted to the ASPPH website at aspph.org. As a reminder, today's webinar qualifies for 1 Certified in Public Health Continuing Education credit. To obtain your 1 CPH credit, please complete the webinar evaluation. You can access the webinar evaluation through the aspph.org website. Click Events at the bottom of the home page, and you will see the webinar description as one of the featured spotlights. Click on the spotlight, and you will find the link to the webinar evaluation. You can also visit shoppublichealth.org and find the evaluation under Certified in Public Health Continuing Education Credit section. The passcode that you will need to include on the evaluation is HSPHPERLC 2014. That's Harvard School of Public Health, PERL 2004. Remember to report your participation in this webinar on the recertification and the reporting system as well. Thank you again for being part of today's ASPPH webinar. Have a great day.
Thank you.
Thanks, everyone.